Alrighty, so I have a fairly good stack of cards here. So,
yeah. And we got a few more coming.
So I haven't really sorted them here, so I'm going to try to sort of distribute the work as evenly as I can. In other words, I'm going to try to get out of doing any work myself. And so I think now that we have, oh my goodness. So, oh man. So hopefully you don't have any plans for tonight. Okay, so I think we have one for Joe Dillon here. So can you explain octreotide versus lanreotide, and in what situations would one work better than another? That's a great question.
Yeah, it is a great question. Octreotide and lanreotide are both artificial forms of the hormone somatostatin. So somatostatin was initially isolated in the 1970s, and the first drug copy of somatostatin was octreotide, initially given short-acting octreotide subcutaneously. And the long-acting octreotide, which you know as sandostatin LAR, was the first one on the market, and then the lanreotide came on the market. Slightly different chemistry, just marginal, but they both do the same thing. They both act on those parking spots, or those little. Dr. Thor showed you the somatostatin receptors, and when they act on the somatostatin receptors, they basically do two things. They essentially instruct the cells to slow down their tumor growth, and they instruct the cells to slow down and decrease their hormone production. So both of them do pretty much the same thing. There are slight differences in how they're given. The octreotide is an intramuscular, so a deeper injection. The lanreotide slightly less deep. I think essentially they're certainly more similar than they are different. There are some people who have a bad response to one of them, having a response of achiness or headaches or other things, and we change them to the other and they do fine. And I think what's happening there is that the chemicals that each manufacturer has put in there to solubilize everything, those chemicals are different. The actual active ingredient is not particularly different. Lanreotide has a slightly longer duration of action. Lanreotide is a single injection of 120 milligrams, which is probably the equivalent of 40 or 50 milligrams of sandostatin. Once you get above 30 milligrams of sandostatin, you're into 2 injections. So certain people find one more comfortable on the butt than the other, and that's an important thing as well. But I don't find these agents particularly different. They're both made to be copies of the same thing, and for the most part do the same thing in the body.
Thank you very much. So we have one question here for Dr. Boltio. So here is actually 2 questions here, but for the patient you presented who had histotrypsy, why did that person regret having it, and why the different responses to histotrypsy?
Oh, no, I don't think that any of the patients regretted having it. It's really super well tolerated. I may have regretted, saying that was the right thing to do under that circumstance. So I think that if I were to take our entire, so we've done around 51 cases now, and probably around 22 or so of those cases have been done for the control of carcinoid syndrome. But that all liver-directed therapies, regardless, you can ablate something, you can catheterize something, and you can surgerize something. They're all very good at cytoreducing the chemical production and improving carcinoid syndrome. So why we were using histotripsy in those circumstances were either someone maybe has chronic kidney disease, that 77-year-old has chronic kidney disease, and so catheter-based techniques are going to be riskier in her, and so if the goal was just to control symptoms, then you're just shooting at the hottest stuff, and that you can do quite effectively. If you can see it, you can hit it. If you can hit it, you can treat it, and I feel very comfortable saying that now. And then the control of symptoms has been quite good. Now, if I were to compare that, say, to liver-directed therapies done in a similar fashion with the control of symptoms and then follow those people over the course of a year, because we've only been doing this for around 15 months, course of a year, and say, hey, how often over the course of the year would you have recurrence or have reemergence of those symptoms? I feel like liver-directed therapies give me a longer, like catheter-based liver-directed therapies, give me a longer than a year improvement in carcinoid syndrome. I can't say that exactly, it's going to be the same. So I don't think I've had any single patient regret it. And I think if we're talking about doing it in higher grade tumors where you have other techniques and or you're trying to avoid the inevitable discussion about whether or not someone would need cytotoxic chemotherapy under those circumstances, I think that's where you are using a less robust treatment strategy. It's only been FDA approved for probably maybe 18 months. So you're using something just because it's a shiny ball, as opposed to using it because it's got a clear-cut indication for what it is you're trying to achieve. I'm not sure that exactly answers the question, so if I didn't answer the question for that person, I'm more than willing to go into more detail with you over lunch.
Thank you. So on that same card, there was a question I think I'll take here. Can you start and pause temozolomide, and then restart while retaining efficacy? In some cases you can. We like to continue the CAPE-TEM for at least 6 to 9 months if there's a good response, sometimes even a little bit longer than that. But there are situations where you have to stop or someone wants to stop, and you can still, if there was a good response, go back to it. We all have those patients who we have treated several times with the same treatment, sort of paused, gone back on it. So yes, that can be done in some cases. So here is, so it's now for something a little different, which I think is a question I am getting a little bit of. So what, and this is for both of you, and what's happening with the neuroendocrine tumor or NEN research in this new political environment? Because we hear about like decreasing grants for research. Any insights on that? I know that I thought this is a great question because I've probably had to answer this 2 or 3 times in the last week.
Yeah, well, I think that is that. Let's just put it this way: we live in the world of the disenfranchised, marginalized people, anyway, because you guys are in the periphery of anyone's attention. So we don't get a lot of grant funding anyway. Yeah. So. When you look at the controversies that is, and you're saying, well, how does that affect neuroendocrine? Well, it's definitely not going to make it easier, but that I don't think that we had a really strong seat at the table anyway. So the people that I think are most vulnerable are people's entire livelihood on breast, colon, lung, or prostate cancer, because those are a good portion of the entire portfolio. And then once you get into the rarer, types of tumors, you're a small proportion of the portfolio anyway. So I would say that our strategy in our cancer center, which is very, very different, is if we can just maybe stay under the radar. We just don't want to be the one that we get cut because they don't know what we are. Mm-hmm. Because that, I mean, the nuclear people, they did lose their job because I think someone didn't know what they did. But yeah, so I don't know how it is in Iowa.
Well, in Iowa, we'll know within the next month or two, maybe. So one of our big funding sources is NIH, and it's the National Cancer Institute, and the National Cancer Institute's budget has been slashed quite significantly. So the reason I say I'll know within the next month or so is that One of the large grants that we have that has funded our neuroendocrine tumor research in the past, we've had an excellent score on it, a fundable score on it. So in any other year, it would be funded. We'll know in the next month or two because nobody knows when the meetings are going to happen.
Thank you. Nope. So I don't think I have anything to add to that. So moving on through the cards here, we have a lot of cards. So this has to do with PRRT. So once the peptide is attached to a receptor, is it drawn into the interior of the cell? And I can take that one. We used to think that was needed when the radioactive chemical in the peptide latches onto the tumor cells, that they can be flipped on the inside, but the path length of the radiation for the lutetium is actually 2 millimeters. So it shoots across like dozens or if not hundreds of cell diameters. So it doesn't have to be what we call internalized. Even if it doesn't go in on the inside of the cell, it will still take care of treating that cell. Okay, moving on. So, well, now that I am on the radioligand therapy, I'll take that one as well. So can I do alpha PRRT after beta PRRT treatment, or is there a waiting period? Yes, you can do it. We have a clinical trial, something called Action 1. Patients who have previously received anywhere from 2 to 4 cycles of lutetium can go on that study if their tumors is progressing. But if the tumor growth happened within 12 months, I believe, from the last lutetium, then you're not eligible for that particular trial. But in the future, I could see us treating those patients with alpha. Don't you think so? Or?
Yeah, I can't remember use. So we just completed the phase 2 PB212 trial of alpha particles that included both the patients who had not previously been exposed to PRRT, and then there was a subgroup of probably around 28 patients who had previously been treated with beta PRRT and then went on to receive 4 doses of alpha PRRT. We had, I want to say, probably around 14 patients on that second arm, and the difference between the tolerance of the two is not to be underestimated. I think that your analogy was quite good with the hurricane coming through that little carport. But that they did tolerate it, and I think we were pleasantly surprised at the response rates in those patients despite their having previously been exposed. So yes, people tolerated it, and yes, I believe that the response rates were quite good. I think that obviously the Action 1 trial is going on. We've only had one patient in that trial because that trial actually is similar to what Thor described in the early trials, or like the COMPETE trial. In the Action 1 trial, you can get the PRRT first, or you go on to another option thing, and that is at the discretion. So it can be double dosing the somatostatin receptor analog, it can be everolimus, it can be sunitinib or whatever, and then if those people ultimately experience progression, then they can flip over and get the alpha particle PRRT. So we have one patient that randomized into that PRRT arm, and they have, similar to the PB212, have tolerated that treatment without significant difficulties. Yes, they had the side effect profile was just a little bit harsher than the beta particle PRRT, and since they've experienced beta PRRT, they know the difference. But the tolerance of it is we just haven't followed that patient long enough to know whether or not the response rate was any different.
Thank you. So, well, I think because we have so many, I'll just move through them. I'll take this one. So please explain the significance of labs before starting each cycle of oral chemotherapy like CAPTEM. When or what labs are important to determine if the patient is experiencing toxicity? And this is a great question. So when you're on CAPTEM, it's expected to lower your white blood cells, platelets, and the hemoglobin, or at least it can do that. And if your numbers are still going down and you haven't really started recovering yet, and if we hit you again with a chemotherapy, it can really suppress your bone marrow. We've all seen these patients who come in with like platelets of 5 and with bleeding, and so it's really just making sure that the bone marrow is on the mend before we dose the next or before we start the next cycle. And super simple. We really only need a complete blood count. We like to check the kidney and liver function, just if something might have happened, because some of these drugs are actually metabolized or eliminated through the kidneys and the liver. So that's that. So I have a couple of somatostatin analog questions here, and these two actually tie together nicely. So let's start with this one, and this is for both of you, all of us. So can long-term use of somatostatin receptor analogs cause loss of the somatostatin receptor on the tumor cells?
It is entirely true that somatostatin receptor analogs seem to wear out after some time, whether that's related to actual loss of the receptors or some other changes in the tumor. I'm not so sure. But you know, when you look at the Dr. Thor told you about the time to progression for some of those treatments. There's a time to progression for lanreotide and sandostatin as well, and so there's a limited time. But what actually underlies that limitation, I'm not so sure. There's a lot of basic science research on treating other conditions continuously, or treating cells continuously, and having the receptors eventually disappear from the cell surface. And indeed, in some of our treatments, such as PRRT, we sometimes run into an issue where we basically kill off many of the cells that are sensitive, that have the receptors, that have the docking sites. So the only cells that are left growing are now the cells without the docking sites, without the receptors. So there are a number of subtleties there.
Excellent. And then the next question here, so this was really good. So is there a way to make sandostatin or octreotide or lanreotide easier to access when away from home? So one of the reasons I can start with this one is that it has to do with the way the reimbursement is for these drugs. So there are some programs for home administration that some patients can be eligible for, especially for, I think, both for octreotide and lanreotide, but not necessarily easy to enroll on. There is a compound out there that has been in a clinical trial. It's a self-administered, short-acting or relatively short-acting octreotide. It's an injection every 2 weeks, self-administered. That trial was called Sorrento. It was an international trial, just completed accrual about a year and a half ago. We're waiting on the results of that. So if that turns out to be, and it was being compared to octreotide or lanreotide, if that turns out to be as good or better as octreotide or lanreotide, and it's super easy to administer, it's like almost like an insulin pen, then that might be a good option. The other thing, just logistically, is that it's kind of hard to handle the octreotide and lanreotide. You have to reconstitute it, mix it, and then it's an awkward angle if you're going to administer it yourself. And but I think most of it is billing. Any additional thoughts on that?
So the Sorrento trial, very interesting, great trial. Look forward to the results. Taking this a little further, there are clinical trials now of tablet forms of octreotide, or tablet forms of chemicals that are synthesized to look like somatostatin. Now, they are only in clinical trials at the moment, really for the symptoms, the carcinoid syndrome, but potentially in the future that will make life a lot simpler.
And that's the Crinetics lady in the back of the room.
Well, here's a good one for the surgeon here in the group. So, is any NCAN patient ever classified as no evidence of disease? I take this after resection, and we could break this down. After resection, if either localized disease or metastatic disease, are you ever NED, no evidence of disease?
Oh, sure. The question is that, so if you have metastatic neuroendocrine and you undergo surgical cytoreduction and we remove all of the disease that we can see, and then you have a somatostatin receptor PET done preoperative and you don't have any avidity, you are by definition then without any evidence of disease. Really the bigger question that I will, ask on your behalf is, what does that mean then with respect to how we manage you? And so if making someone without any evidence of disease with a surgical cytoreduction in the metastatic setting, the stage 4 setting, does that mean that you're going to revert to watchful waiting? And I would say that you could get, I don't know, probably 10 of us or 12 of us, and there would be differences of opinion. Thor had gone over the fact that just because you have disease does not mean that watchful waiting is unreasonable. There are programs that will sort of better understand the biologic behavior before committing you to any treatment. So personally, once again, I don't think there's any data to suggest that you need to be on active therapy if the ultimate treatment strategy that you took got rid of all measurable disease. So the short answer is yes, you can be rendered without any evidence of disease, even if you had metastatic disease at diagnosis. And yes, it does have implications, because I think many of us would feel comfortable following that patient off of somatostatin receptor analogs.
I just think that brings up one thing about, so no evidence of disease means that with the best imaging that we can do, we can't find anything. Well, the best imaging we can do is to get down to 3 millimeters, 4 millimeters, 5 millimeters, which is 2,000 tumor cells. So if you have 300 tumor cells sitting somewhere in a lymph node, we can't see it. You have no evidence of disease. There's disease there.
So I have a couple of questions I'll try to address quickly, just making sure we get through everything. So one here is a really interesting question, actually both are. And what is the incidence of bone metastases in patients with neuroendocrine tumors, and why are those metastases so different compared to other cancers? So we are now finding that we have, after we started doing this SSTR PET imaging, that maybe 5 to 10% of patients will have bone metastases, and they always had these bone metastases in the past, or patients did have them, but fractures are relatively uncommon. There are at least 2 or 3 studies that suggest that if you have bone metastases, your long-term outcomes might be slightly worse, but we're now looking at probably close to 2,000 patients who had SSTR PET imaging. We find the bone metastases probably in about 15%. Fractures are really rare. So it's almost as if these tumors just sit quietly in the bones. They don't eat away of the structured bone. So fractures, I would say, are really uncommon. But we do see them. We do see pain and fractures. Occasionally we have to radiate and even do some surgical procedures for that. The other question here, here's someone who had ocular cellulitis, so infection around the soft tissue of the eye from dry eyes, and was told this would be common for cancer patients. Well, not necessarily for neuroendocrine tumor patients, but some of the newer targeted agents do have some dry eye side effects that might actually put you at increased risk of such infections. But for neuroendocrine tumors, unless you're on one of those medications, probably not a big risk. So let's actually move into the next question. I think I found one really good for Dr. Dillon here. So this has to do, actually it's a question in several forms of this, and let me see, yep, there we go. So the other one is also good for him too. So after 6 months of lanreotide, my hemoglobin A1C jumped to 6.4. It's about 10% jump. And since I need to continue the lanreotide, how do I come up with a plan to deal with this? And so the 3 sort of questions there would be in terms of nutrition, medications, exercise, and what else? And I will throw a curveball at you as well. So what about GLP-1 agonists? So these are the medications used for diabetes that can help you lose weight, so like Ozempic and similar drugs. So it's a complex question. Rising hemoglobin A1C. This is why I invited him to the stage.
Let me see if I remember all the parts. So to start with, lanreotide and octreotide. There are somatostatin receptors on the pancreas, on the normal pancreas, both on the part of the pancreas that makes your pancreas digestion enzymes, and the part of the pancreas that makes your insulin. So unfortunately, there will be a decrease in insulin production with anybody on octreotide or lanreotide. And so that decrease in insulin production is going to result in an increase in blood sugar level, because the insulin is what decreases your blood sugar. And that is baked into the use of these medications. So in general, I will see that people's hemoglobin A1C, that is a measure of their average blood sugar over the prior 3 months, that their hemoglobin A1C goes up by 0.3 to 0.5%. So I guess this was a relatively generous increase of slightly more than that. So, unfortunately, with that, once the hemoglobin A1C gets above 6.5%, we call that diabetes, and we call a person who has that sort of number because they're on lanreotide, we call that diabetes, just as we call diabetes with in people who are not on those medications. And the same general protocols apply. Watching your weight, decreasing weight if possible, watching particularly the carbohydrate content of diet, increasing physical activity. Those are the sort of the main three initial things that you can possibly do in terms of getting your own blood sugar down. So those apply here as well. And then we get on to medications. And in general, the medications that are used for common or garden diabetes, i.e. diabetes that does not occur in people who are on lanreotide, the medications are the same, except for the question about the very new, or relatively new and very exciting medications called GLP-1 inhibitors. They're sometimes called GIP inhibitors. The most well-known of them are Ozempic and Mounjaro. The problem here is that Dr. Thor showed you the picture of the somatostatin receptors on the neuroendocrine tumors. Unfortunately, some neuroendocrine tumors have receptors, have docking sites for Ozempic or Mounjaro, GLP or GIP. And what some research colleagues at the University of Iowa have shown is that if you take a piece of tissue from a surgery and grow it in a test tube, and that tissue happens to be one of those tumors with a GLP receptor, if you add in Ozempic, that piece of tissue grows. So Ozempic and Mounjaro can be, theoretically they can be growth factors for neuroendocrine tumors if the neuroendocrine tumor happens to have the docking site, the parking site, the receptor for those substances. So what we have found in our research briefly is that people who have neuroendocrine tumors starting in the small intestine, almost none of them have GLP receptors. So almost none of them have theoretical ability to be acted on by Ozempic. A majority of them probably have GIP receptors, so a majority of them have the theoretical possibility to have a growth effect of Mounjaro. So I don't like to side with one company or another, but what I tell people, if they want to be on these agents and they have a neuroendocrine tumor that starts in their small bowel, choose Ozempic over the more effective for obesity, Mounjaro. There are other names for those compounds. So Mounjaro is Zepbound and Ozempic is Wegovy. In the pancreas, however, there are people who have the potential to have activity of either Mounjaro or Ozempic, and so that's a problem because up to now we don't have a commercial assay, a commercially available way of figuring out, okay, does my tumor have a GLP receptor or a GIP receptor? We don't have that yet. We're working on it at Iowa. Other people are working on it. Hopefully we'll be able to get that information. But small intestine, you want to be on one of those medications, Ozempic, not Mounjaro. Pancreas, that might be a problem for both of them. Duodenum, certainly a problem for both of them. So lung, about 10% of people with lung neuroendocrine tumor have a receptor for the Ozempic compound.
Thank you, super helpful. So, so here we have one for Dr. Molicio. So here's a surgery question, and this is something we get in the clinic a lot. So if someone is not a surgical candidate initially, in this case, primary duodenum with the metastases to the liver and spine and doing well on octreotide, is surgery ever indicated to remove the primary tumor or liver tumors after a period of stability, or if the tumors get larger, or is surgery never to be considered in stage 4?
Oh, well, surgeons never use the word never. So I think that if you look at the data that supports surgery, and I think that Jim Howell will probably go into it in more detail, is that you want to make sure that you are doing it evidence-based. And so this example of duodenum is that duodenal neuroendocrines, and now I just learned something from Joe Dillon, which is pretty much almost every single time he sits on a panel, is that the unique features of very particular cases, because duodenals that metastasize are some of the most unpredictable neuroendocrines that we deal with, because usually they're kind of the most boring, non-invasive, don't metastasize, and so there are unique features of those that make them very complicated. So that's one where I would say I put the whole menu of options down for almost every patient, and then I describe to them why I would not take that approach at that point, why I would not take that approach at this point versus all of these other options. And so when you have multi-organ site involvement, which definitely sounds worse than it is in neuroendocrine, where you've got a duodenal liver bone, I think that the surgeons just have to be quieter. Because in general, systemic therapy is appropriate, whether or not that's systemic therapy with something like a somatostatin receptor analog versus PRRT. It's just that our data just is not as strong in those cases, so we'd have trouble actually convincing you of the investment in that operation. Now, if you were to say, oh, but if you even have slow growth over time of the tumor in that area of the duodenum, oh, well, that's totally different. Then we do that with palliative intent, but we don't necessarily put you through further complications that would do more than is necessary to meet that treatment goal. But if it was the duodenum and I had one little chip shot in the liver, you better believe that we would be doing it with palliative intent so you don't bleed, perforate, or obstruct from the duodenum, and we'd be removing the thing in their liver to meet the 70% surgical cytoreduction. But I think that when people are saying you're not a surgical candidate, I wish that people would just say, hey, I think at this juncture, in a cancer that's got a lot of treatment options, is about leaving your treatment options open. Surgery of one of those treatments, and it is rarely in a metastatic duodenal going to be the first or second line approach that you're taking.
Thank you. So I think one more short question. I still have 5 cards left. I'm going to save for later. So I'll do a quick one. And I have a short casual observation. All of you have better handwriting than I do. And, but that probably,
you're a doctor.
That probably comes as no surprise. Thankfully, I do my orders electronically now. So here is, I think, if you have any idea about why patients with no obvious progression over 10 years suddenly have very active tumor growth? Well, this would be particularly concerning, I think, in pancreatic neuroendocrine tumors, and sometimes the tumor grade changes over time. They can flip from grade 1 or grade 2 to grade 3, or even flip from a well-differentiated neuroendocrine tumor to a poorly differentiated neuroendocrine carcinoma, and occasionally it could be a different tumor. So I'd say if that happens, if there's a notable change, especially in one lesion out of many, biopsy again. So I think we'll stop there and save the rest of the cards for the second Q&A.
I need to go with everything with you.